This week on the BackTable podcast.
As ENTs, this is our disease to really quarterback. You know, we have so many good colleagues in other adjacent specialties that can help us, but really it's our anatomy, and I encourage us to be more proactive, both with our physical exams and just our communications of the importance, especially of nasal obstruction in treating obstructive sleep apnea, especially CPAP failures. So I think the whole point of this tonight is to really remember the nose in treating these patients.
Hi, everybody. Welcome to the BackTable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. Now, a quick word from our sponsor.
Aerin Medical offers innovative, non-invasive treatments that help patients breathe easier and sleep better. VivAer has been clinically demonstrated to significantly improve sleep quality, daytime sleepiness, and reduce snoring in patients with nasal airway obstruction. RhinAer has been shown to help more patients fall asleep with ease, and twice as many report frequent nights of good sleep after treatment for chronic rhinitis. Performed in an office or OR setting. No incisions, no implants, just lasting relief. Ask your ENT about VivAer and RhinAer or visit AerinMedical.com to learn more.
Now, back to the show. My name's Ashley Agan, and I will be your host today. I have the pleasure of having two guests on the show today, Dr. Keith Matheny and Dr. Ashwin Ananth. We are going to dive into nasal airway obstruction and how that relates to sleep. Welcome to the show, guys.
Thank you, Ashley. Good to be here.
Thank you so much for having us.
So before we get started, let's just kind of tell listeners a little bit about yourself and about your practice and experience in treating patients with, OSA or sleep disordered breathing, et cetera.
So I'm Keith Matheny. I'm in community practice in North Dallas, not too far from where Ashley practices. And I've been in this current role for 22 years. I grew up here in Dallas, but did my training med school in Houston and then did my residency at Vanderbilt in Nashville. And, my story has a couple parallels in addition to my clinical practice, which emphasizes rhinology and sleep, and specifically where the nose is involved in sleep disorders. I have a lot of other interests in companies and the business aspects of ENT, how we run our practices, and some other technologies too. Very diverse career, but I really love each aspect of it.
Cool. How about you, Ashwin?
I grew up in Shawnee, Kansas, and medical school, finished at Tulane in New Orleans and stayed on there for ENT residency. I did a sleep fellowship at Jefferson in Philadelphia, and now I am in community practice in Alabama, in Baldwin County, a place called Fairhope, South Alabama, very much a coastal place. And I have been in that practice since graduating from fellowship. It's an area that really needs medical care, which is great for my practice because I do about 50% sleep and about 50% general ENT. And it could be either way. I could pick all sleep and I'd be busy, and I could pick no sleep and I'd be busy with everything else that we do. So I've chosen to make my practice about half and half, and I do the gamut of sleep medicine as well as focusing on sleep apnea, OSA surgery. So I'm lucky to have a very busy practice, and I haven't dipped my toes into anything other than that yet, but I'm enjoying what I'm doing, very, very busy. So that's me.
Cool. And with your sleep fellowship and in practicing sleep medicine, is that mostly focused on the kind of sleep disorders we see in ENT as far as like obstructive sleep apnea and stuff? Or are you also seeing like other sleep stuff like parasomnias and, restless leg, and like, are you doing medical management?
Narcolepsy, stuff like that.
I do.
That's
I
my
do
question
it
too.
badly. Yeah, I can do it, kind of. So I was lucky enough to have a fellowship where I had a lot of specialties train me. So I was trained by psychiatrists, neurologists, pulmonologists, as well as internal medicine doctors and surgeons as well. So up at Jefferson, they have a good program where they kind of meld the surgical training with the requirements for board certification and multi-specialty training. So I'm not the best at it. Let's be honest. I'm better at doing surgery than I am at prescribing medicine, but I can recognize and diagnose the disorders. And unfortunately, in our community, there's not too many other people. There's about 2 other good board certified sleep doctors that I refer to, complicated cases, but I do, let's say, dip my toe in insomnia treatment, in parasomnia treatment, prescribing medications for daytime sleepiness, narcolepsy, things like that. But the real bread and butter of my sleep practice is CPAP alternatives and management of OSA.
And that's a good segue, because that's what we want to talk about today is, the patient who is snoring or has obstructive sleep apnea or hates their CPAP or refuses to ever be tested because they know they don't want a CPAP. They'd rather die than have a CPAP, so they're not even going to get a sleep study. So let's talk about that patient. So how do you guys think about these patients when they're presenting in your office? How does that look?
Well, I've been at it a little bit longer, and so I think back, if we had recorded this, if there was such a thing as podcast 10 or 15 years ago, I guess they were just starting, and you asked me, do you do sleep in your practice? I would have said, absolutely. But what I meant back then is I saw snoring patients and I triaged them. So usually those patients are dragged in by their bed partner, by their ear or their collar, and thrown into my chair, and I'm told to fix them. And so what we would do is send them elsewhere for a sleep study. And many times we would never see them again, or perhaps we would get them back to discuss the sleep study, but that was interpreted by somebody else. And then maybe we would write a CPAP prescription or discuss other treatment options. And so over that 10 or 15 years, that's completely changed in my practice, at least, where we first brought the diagnostics in-house and began doing home sleep testing. We, in my practice, currently use the WatchPat test from Zoll-Itamar, and we've used that for 8 or 9 years. There are many other good ones on the market. And that we went along well for a couple of years and noticed that patients love that. They love being able to stay with their initial physician for the diagnosis and the discussion of treatment options. But even then, I would either write a CPAP prescription or discuss an oral appliance. These were in the days where Inspire was really just coming to market and other surgical options weren't real desirable for patients. And admittedly, Ashwin, we were not thinking about the nose with regards to sleep. At least I wasn't, and we weren't having the discussions that thankfully we do now. And so that next step was bringing the oral appliance program into our office. And what I mean by that is here in Dallas, we had for decades referred to a sleep dentist in our geographic area. But just that drive from my office to the dentist completely changed the economics for the patient. So once I was able to bring the dentist into my office, I was able to run those appliances through the patient's health insurance. And so maybe if I had 10 patients before that I thought an oral appliance might be a good alternative to CPAP, maybe one of them would actually follow through because it was quite expensive. It was out of network or completely cash pay. But just having the dentist in my office, we've moved that up to maybe 6 or 7 out of 10 that I feel are good candidates for oral appliances are actually receiving them. And, oh, by the way, saving a lot of money in doing so. So that was really step 2. And relatively recently for me, Ashwin, I do hope you talk a lot about your Inspire experience as well. 2 of my younger associates are doing the Inspire implant, and we're, as people told me for a while, we've been amazed at how many candidates there are, but also how much interest there is. And I would say kudos to Inspire for raising so much awareness that there are alternatives to CPAP. If that's just not for you, you don't have to just live and /die from untreated obstructive sleep apnea. You actually have other options.
Yeah, I totally agree with everything you said. I have much more limited experience in practice than you, so I haven't seen the evolution, but I've seen everything you said come true. So if you can bring some of the diagnostics in-house and as many treatment options as you can offer in-house, then that patient will stay with you and you'll be able to follow them along as a journey to take care of their sleep and their health, really.
Patients love it. They love having a one-stop shop. I mean, you're really unique and great in that you know so much, you're boarded in so much about sleep. I mean, patients can, no matter what, I mean, they can stay with you for their entire treatment. And I just think it's important to say, I mean, I know that we have a variety of listeners, but a lot are otolaryngologists, and all three of us are. It's always amazed me, even as a resident, that we aren't the primary specialty that treats sleep apnea. So this is a disease that occurs right here. And yet it's treated by the doctors of the brain and the doctors of the lungs. And they do a wonderful job. That's not a knock on the pulmonologists and the neurologists. It's a knock on our society that we didn't take this by the reins and really drive therapy and treatment. And so I'm glad to see that there is much more interest amongst our colleagues in doing so finally.
Yeah, it's absolutely true. I think that OSA is a field with a fellowship behind it. That's the sleep fellowship. But even with the sleep fellowship, OSA is going to be 90% plus of what a sleep physician is treating. And OSA is an upper airway disorder. Your brain is telling you to breathe. Your diaphragm is trying to bring air into your lungs, and there's obstruction in the upper airway. And we're biased. We're all biased. But nobody knows that better than us, than knows the pharynx, the larynx, and the upper airway. It's our wheelhouse. So understanding that you can impact an OSA patient more meaningfully than a lot of physicians who do sleep medicine can is really important. And I feel that all otolaryngologists, whether they want to be or not, are probably really good sleep doctors for OSA. Another thing I'll say, and you highlighted it with the Inspire comment, is that when a patient sees a sleep physician who is not a surgeon, there's really only one answer, and that answer is CPAP. And a lot of patients will pick up on that. And eventually, patient says, the CPAP's really bothering me. I don't like it. It's blowing in my face. It's waking me up. I hate it. And the doctor says, yeah, you need to wear your CPAP, or we'll try you on BiPAP, or we'll try a different mask. And then the patient comes back and maybe it's a little better, maybe it's not. And the doctor says, well, yeah, you really need to wear it. You're going to die if you don't wear it. And at some point, that patient will become cognizant of the fact that there's only one tool in the toolbox there. And that patient will put the CPAP under their bed, or they'll get rid of it, or their insurance will reclaim it because they're not using it. And what I've seen in my couple years of practice is that there are so many of those people out there that have put OSA treatment, they've forgotten about it, and they're sleeping in a different room as their bed partner, or they're scuffering. They've developed atrial fibrillation.
Drives me crazy, right? Yeah. Because I see this, snoring is a frequent topic of comedy routines, right? But it's not funny. This is the most severe disease that an otolaryngologist takes care of, except for head and neck cancer. And we're only really treating about 1% of patients longer than 90 days that have OSA.
1%? One?
The quarter of this planet, 25% of this planet, is walking around with diagnosable OSA. I'm just talking about OSA here. Of that, even in the Western world, we have only diagnosed 10% of people that have OSA. Of that 10%, we're only treating 10% longer than 90 days. So yes, Ashley, if my math is right, it's 1%. Imagine if we were treating 1% of head and neck cancers. That's what we're doing with this, and it's just as morbid and it's just as fatal. Maybe not as quick as a bad laryngeal, squamous cell, but just as fatal eventually.
Yeah, so what I've seen with the marketing campaign with hypoglossal nerve stimulation, namely Inspire, the patients see a commercial and they see, some joke about snoring at the dinner table, and then click a button, OSA's gone, no mask, no hose, just sleep. And these people come out of the woodwork. And I've been seeing patients who said, yeah, my last sleep study was 20 years ago. When's the last time you wore a CPAP? 19 years ago. What have you been doing since then? I've been sleeping in a recliner in a separate room, and I'm miserable, and I take a nap every day for 4 hours, and my boss is about to lay me off, or something like that. But the burden of untreated OSA, as Keith is referring to, is absolutely enormous. I don't think that in a similar way to bariatric surgery, I heard a bariatric surgeon tell me one time, we're not going to operate our way out of the obesity epidemic. In the same way, I don't think we're going to operate ourselves out of the OSA epidemic. But this is where the role of the nose is huge, because we can recognize that, and that may be the barrier to treatment that can get a lot of patients back in the game of being treated with their OSA. So whether that be getting back on CPAP, or whether that be a bridge to other CPAP alternatives, it's additive therapy. And again, a perfect correlate with head and neck cancer. I'm not trying to say that OSA is cancer, but the way that we learned how to treat head and neck cancer was, if you have a head and neck cancer, we diagnose it and we treat it. And if it recurs or you get a second one, then we don't say, hey, we gave it a shot, sorry, you're dead. We say, hey, let's do salvage therapy, or let's do something else. So that's the way. And even it parallels on my notes. This is my treatment history for OSA with this patient. So the way I say it is, if you're going to be on CPAP, we can dial up the CPAP and we can blow it away. But if we're going to do something else, then we're going to get it as best as we can. And it might not be one thing. It might be a treatment course.
Multi-level, right?
Yeah, multi-level. And then the nose will only help whatever else we decide to do, if any.
Well, the literature says that 70%, up to 70% of OSA patients have significant nasal obstruction. And I find that certainly before we had some of the modern therapies, which we'll talk about over the next few minutes, I'm sure, we, even as otolaryngologists, ignored it other than looking at a deviated septum. And I will pause here, our friends at the third-party payers, friends in air quotes, they love to dissociate certainly a deviated nasal septum, but really any nasal airway obstruction from OSA, to the point that you have to be careful documenting those ICD-10s in the same note, because one may deny care for the other. And yet, as I always say on this topic, the nose is central, literally and figuratively, in sleep disordered breathing. And so I guess, Ashwin, my question to you is, since you trained much more recently, how much were they hammering home nasal obstruction as you were looking at sleep disorders? Or I guess even more, when you were training with the non-otolaryngologists, the psychiatrists and the pulmonologists, what did they pay any attention to nasal obstruction, or was it complete mystery to them?
Well, here we go with the bias, right? So if you're looking in a nose with an otoscope, then you're not going to see it right. You got to look with the speculum, and you got to have to look at a lot of noses. And that's what we do best as otolaryngologists. We're able to look at our physical exam and understand what we're seeing and correlate that with what the patients are saying. So yeah, in my fellowship, the neurologists and the psychiatrists and the pulmonologists that I train with were much, much better at managing medications than I was. But even during my fellowship, they'd say, what do you think about that nose? Do you think that this is that? And I'd be like, no, that's not that. And so anyway, I think that the emphasis has to come from us, because, any otolaryngologist in practice has been referred a patient for nasal polyps and it's the inferior turbinate. You have to be able to look at it and understand what's going on. So is their nose contributing to a patient's intolerance of CPAP? Is their nose contributing to mouth breathing? Is their nose contributing to arousal threshold where they're not breathing well through their nose? They kind of choke and wake up, and that's making them have a hard time getting into deep sleep. So the nasal exam, there's no different nasal exam for sleep than there is for any other thing, I think. Just look in their nose and you'll know what to do.
Yeah, true.
Yeah. Keith, can we go back to your comment on third-party payers not, or, disassociating like a deviated septum or nasal obstruction with OSA? Like, so you're saying like if someone had both diagnoses, then that could be problematic for coverage of certain procedures?
Yeah. What I've noticed, it's anecdotal. I'm not claiming to be Karen Zupko here, but I know a little bit about reimbursement. And if there's this patient that all I've really found of significance on their physical exam is a deviated nasal septum, perhaps some nasal valve collapse, but I also have the ICD-10 of OSA, whether I made that diagnosis or they came in with it. I've had many, many septoplasties denied because that is not an accepted treatment for OSA.
Oh, wow.
Even though I'm treating the deviated nasal septum, just having that ICD-10 in the list, I've had them denied. So I've learned to be very careful and dissociate them at least by 90 days. I mean, again, it's a game. I try to always be real on these podcasts. I mean, that's what it's like to really practice medicine nowadays. It's a game, and a frustrating game that the rules change every 90 days. But what I do is usually I'll ask the patient, okay, what do you want me to address first? If you want me to do a home sleep test and evaluate your sleep, let's do that first, and we'll deal with your nose later. But what I vote for is, especially now that we know so much about the contribution of nasal airway obstruction, I say, let me treat your nose first, heal up from that, whatever we do, and then let's do the diagnostics, because you're going to be better. And then we can make some good clinical decisions if we need to do anything in addition.
Got it.
So that's at least how I handle it, Ashley.
Yeah, that's helpful. And so when you have the patient coming in who does not have a diagnosis of OSA, let's say it is that classic patient that's coming in with their partner and fix the snoring and they're falling asleep in the afternoon, it seems like there may be an issue. Now that you're paying attention more to the nose, as we're kind of unpacking this nasal obstruction part of it, are you asking more questions about nasal obstruction and allergies and runny nose and that sort of thing when you're taking that initial history?
I really am. And Ashwin, your comment earlier was spot on. I mean, this should be a part of every patient that we see. And it is to some extent, but I think, Ashley, I'm taking much more care to ask even about postnasal drip, rhinitis, congestion, those may be traditional allergy symptoms, because those also negatively affect sleep quality. So absolutely, I'm trying to, essentially, as we should all do, ask all these quality of life questions, and that helps us formulate our recommendation for the patient.
Yeah, my initial sleep history I see a lot of these. I see like probably 10 patients per day who are new patients referred from primary care for sleep medicine, not necessarily for an ENT evaluation, just, hey, new onset AFib or snoring, choking, gasping, or falling asleep at work, or Department of Transportation physical. My history is really just a sleep history. What time do you go to bed? How long does it take you to fall asleep? Are you waking up a lot at night? What time do you wake up? Any medications associated with that? Are you falling asleep during the day? And then just when I'm examining the patient, I say, do you have trouble breathing through your nose? And then I look in their nose. And I guess the kind of unpacking that, my goal is not to do a septoplasty on every OSA patient. My goal is to get those people treated. But yeah, the nose is super important. So it's not a huge focus of my initial history, but it is a huge focus of my history on a CPAP-intolerant patient, especially when they say that the pressure was not, they weren't tolerating the pressure. So I think that pressure intolerance with the CPAP is a huge harbinger of nasal obstruction as the cause.
Absolutely.
So if people say, I can't tolerate my CPAP, can't handle it, we should be thinking, okay, what's going on in your nose? Yeah.
Mm-hmm. You have your patients who are like, I just can't have anything touching my face. I was a tanker in the Army and everything bad happened. And that's a special population, the veterans, and they deserve special consideration. Then you have other people who it's inconvenient. My partner makes fun of me. I'm dating. I don't want to wear a CPAP, something like that. And then you have people who say, it's just blowing it's just blowing on my face, and it's blowing so hard. And it makes my nose dry and it hurts, and it's just blowing so hard, and that thing has to be so tight. That last one is the one who I'm really looking at their CPAP machine's compliance report to see what type of pressures is it blowing. But a lot of times those people aren't using it. They haven't used it for years. I don't have access to that. That's the one where I'm very aggressive in treating their nose.
Will they also report a lot? Will they also say like, oh, my nose is really stuffy, I can't breathe through my nose well, or not necessarily?
I think so. Oh, there's this whole thing with nighttime nasal obstruction. I breathe okay during the day, but then when I lay down, I can't breathe through my nose gets stuffed up. And there's certainly an association with that and mouth breathing. And mouth breathing changes the dynamics of the jaw and the tongue and the pharynx. And, there's data that treating the nose alone will not cure OSA. However, in my practice, anecdotally, I find that treating the nose, especially in mild OSA, can allow people to keep their mouth shut. And keeping their mouth shut can make very big dynamic changes in the pharynx.
I concur. I think with mild OSA, it can be curative, but maybe that's what you're saying, Ashwin.
Yeah.
Because then they can shut their mouths and have the normal aerodynamics of sleep.
So is that a question you asked too about mouth breathing? Are you mouth breathing during the day or when you're sleeping, or not necessarily?
I don't really care. This is my pet peeve. So the patient I'll set them up for CPAP, and they'll go to the DME company, the durable medical equipment company, to be set up. And the DME company will ask them, are you a mouth breather? And if they say yes, they'll set them up with a full face interface rather than a nasal interface. The nasal interfaces have been shown to have lower pressure requirements, better adherence, and overall predict better long-term success than full face interfaces. My personal belief is that if you have sufficient airflow through your nose, that you'll shut your mouth. And when your nose is obstructed, that's why you open your mouth. So even somebody with nasal obstruction who we haven't treated yet, some of those people, if you put the CPAP on them and it forces air through their nose, it's not great. The pressures are too high, dries out their nose and all that, but they'll shut their mouth even though they were a, quote, mouth breather before. If you put them on a nasal CPAP, they'll shut their mouth.
Actually, I see a new T-shirt coming from the BackTable store. Shut your mouth. How many times have we already said that?
It used to be an insult. You're a mouth breather.
Right. Now everybody tapes their mouth shut, right? Yeah. At least that's what TikTok says to do, right? Tape your mouth shut.
With your exam for these patients, is it a different exam, or is it the same exam that you do for any patient coming in?
For me, it's the same.
Yeah, same for me, Ashley. We learned a lot in the days when a company called Spyrox was commercializing the Latera implant. And I've continued that now that Aerin Medical has the VivAer treatment for nasal valve collapse. We were taught as residents that nasal valve collapse wasn't that common, like a single digit or teen percentage of patients. But I think that bias was because we didn't really have a lot to offer patients outside of functional rhinoplasty. And so a lot of patients just didn't have access to that procedure, so we didn't look. And with Spyrox first and Aerin soon afterwards, it really raised at least my awareness, and I think a lot of our colleagues, first of all, to examine the nasal valve and look for static collapse. Of course, that's usually obvious, but dynamic nasal valve collapse. And we realized, there's a heck of a lot more patients that have this than we thought. So that has become now an extensive nasal exam, but including looking at the nasal valve dynamically has become a part of every exam.
And when you're looking inside the nose, do you medicate with Aerin? Do you look first and see what it looks like before, and then you spray so you can look a little deeper, or does it matter?
I usually don't medicate them, just to use a speculum and a headlight. Usually by the time I'm scoping somebody, my staff is already in this, sprayed in some oxymetazoline and some lidocaine. So they are decongested unless I specifically say no. But again, that's more important when you're looking at the turbinates and even the swell bodies. I think you can still identify and do a modified caudal, whether they've had Aerin or not, and still get a good idea if that might help them treating the nasal valve.
Yeah, I do the modified caudal. I'm probably the outlier. I don't spray anybody's nose unless I'm doing a procedure on them. So unless I'm like doing a debridement after sinus surgery or a nasal procedure on somebody, I don't spray anybody. And I do flexible and nasal endoscopy. I do rigid nasal endoscopy. I just try to be gentle. Yeah. I had I had an experience one time where this old lady got like, I didn't know anything was wrong. I sprayed her nose and then I scoped her and everything was fine. And then I got like a handwritten letter in the mail 2 days later that she had got coronary vasospasm from the Aerin and ended up in the cath lab. And they told her it was from the Aerin. And she wrote me this letter that she wouldn't be coming back. So I called her and everything was fine. But yeah, don't spray anybody.
Yeah, now nobody gets Aerin.
Yeah, she ruined it for all of you.
She ruined it for everybody.
Yeah. Yeah, if they ask for it, I tell them like, more people complain about the spray than they complain about the scope. And if they're like, no, you better spray me, then I spray them. So.
And are you doing a flexible, like I would assume you're evaluating the entire upper airway. So you're looking in the nose and then you're going to kind of go back and look at the palate and pharynx and, base of tongue and kind of the whole airway.
I try to do a flexible endoscopic exam that incorporates nasal endoscopy and flexible laryngoscopy on all my new OSA patients. I try to do it on all new patients just because I feel as an ENT, that's something that nobody else can look at.
Yeah.
And we're at the end of the road and you're on the hook for that. So try not to miss anything with that stuff. But I do it. I think that your oropharyngeal exam is probably best accomplished with a headlight and a tongue depressor. But I do really value looking at the nasopharynx and the velum and the posterior nasal cavity with a flexible or rigid scope.
And when you're looking in the mouth, do you ask them to stick their tongue out or keep their tongue in? Say, do you do it with the tongue depressor, without the tongue depressor?
There's the Mallampati score, which was popularized by anesthesia to predict ease of intubation and modified by Friedman into the Friedman tongue position score. And both of those are supposed to be opening your mouth with your tongue in its normal position. However, I can do that for you and show you a Mallampati 4 airway, and then I can do it again and show you a Mallampati 1 airway. And I think it has to do with the way that you activate your tongue muscles, and some people relax their tongue and some people don't. So I try to get a good look. I tell them, put your tongue back in your mouth and just open your mouth. Try to relax your tongue. Try to say ha, 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 and that elevates the palate. Usually they relax their tongue. If they can't do it, then I just got to see if they have tonsils or not, or what's going on with the tonsils. I take a tongue depressor or 2 tongue depressors, and I jam on their tongue with it, and I just look.
It's always been, even as a resident, and maybe I'm always been a contrarian or always thinking of a better way to do things, but it never made sense that we're examining these people sitting upright. That's not how we sleep. So I always thought those classifications were funny. I mean, and even our anesthesiologists look at the patient in the bed in the pre-op area kind of at a 45-degree angle. Well, that's not how you're going to intubate them. If they're going to do that, I feel like they should be laying flat at least, even though they're still awake. So they have more muscle tone than if they're in deeper sleep. I find the same thing, Ashwin. It's hard to predict. It's how they hold their tongue. It's how much of a anticipatory gag reflex they have. I mean, it's a very inexact science.
I put a lot of my weight on my exam during a drug-induced sleep endoscopy.
Right.
I do a much more detailed exam with the patient anesthetized with propofol regarding their airway, especially if it's a patient who's never had a sleep study, never been on CPAP. I know that we're going to go through all those things before I do any surgery, probably. So just in my practice, the sleep endoscopy is basically the jump off point for any CPAP alternatives. If you're coming in and you've tried CPAP and it's not working for you, then we're talking about doing a DICE.
Whether or not you're considering Inspire, you're just doing it anyway.
Yeah, that's what I'm going to do for every single OSA patient who isn't tolerating CPAP. That is how I evaluate for mandibular advancement devices, which we make in the clinic. That's how I evaluate for any type of tongue-based surgery.
How is that reimbursement? Or are you doing concurrent procedures like, for example, the VivAer, or how are you getting that paid? I'm really curious.
So the way I live in a strange insurance microcosm that is very different and almost certainly worse than yours, called Alabama. So, I've never been denied a septoplasty, and I'm sure I will be now that I'm saying this.
United Healthcare is listening and already taking notes on you. So good luck.
Yeah. But anyway, I have never been denied a sleep endoscopy either. So basically, if somebody has OSA, I document in my note that they have obstructive sleep apnea, that they're intolerant of CPAP. We book the sleep endoscopy. So if we're going to get into the financials of it, it reimburses well enough in a ambulatory surgery center in my environment that they want me to do as many as possible. It reimburses so well in the hospital that they want me to have a whole day in the endoscopy unit where that's all I do. The surgery center wants me to bring it there. The hospital says, we really want you to bring it here. And that's just DICE. The way that I speak to patients about it is we are going to try and see what we can do to treat your OSA other than CPAP. And I'm just going to go and look. I'm not going to guess. We're going to go and look and see what pattern of collapse your airway has. And then I'm going to wake you up and send you home. And then we'll come back to the clinic and we'll talk about it. Now, also, if you have nasal obstruction, we can treat your nasal obstruction at the same time, whether that be radiofrequency, whether that be operative septoplasty and turbinectomy, or whether that be functional rhinoplasty, whatever it might need to be. But if we treat your nose and then I bring you back to the clinic and I explain the sleep endoscopy findings and you don't like what I'm telling you, or there's not a great option that suits you and me, or I really just don't think there's a really good way to treat your severe OSA, then by doing the nasal surgery, we've teed you up to succeed with CPAP. We'll give it another shot. And if there is something else, then treating your nasal obstruction will only help that succeed better. So of all the things I offer in my clinic, whether that be sleep or ENT wise, I'm very aggressive in offering nasal surgery or nasal treatment to patients with OSA because I feel like it's very safe. It's pretty much going to help them one way or another. And they've been appreciative.
Yeah. So your DICE patients already have had a sleep study. These are patients that already have a diagnosis of OSA.
Yes.
I'm just curious, how is your reimbursement? So I know the facility fees are good for the hospital, and
it's awful.
Yeah. So I mean, how do you feed your family if you did a whole day, for example, in the hospital?
Thyroids and sinus surgery.
That's the reality, right? I mean,
yeah.
You know.
Logistically, what we do is I've been lucky enough to get endoscopy units. So I run a full OR day, but I can also do 6, 7, 10 DICEs in between cases.
Okay.
So I'm not picking, do I do a DICE or do I do a thyroid parotid, vest, whatever it may be, ear tubes, tonsils, whatever. I do both. And the OR is moving and the endoscopy unit's moving. So it's not a great moneymaker. We were doing it in the clinic with an anesthetist that would come to clinic, but reimbursement wise, there's no code for it. So you're just getting a 31575, which is a flexible laryngoscopy, which pays what it does in clinic, same as on an awake patient. So I'm not going to say it's a waste of time, but it's not the best use of time.
It's not economically viable. Yeah.
Correct. Coupling it with nasal procedures, though, saves the patient a trip under anesthesia, gets diagnostic data, and does some therapeutic intervention, and then it will pay a lot better too.
And then Keith, for your, who gets a DICE in your practice? Like, how do you decide? You mentioned that you typically will try to treat the nose first before maybe even doing the sleep study. What's your thought process?
I personally don't do a lot of DICE because I guess I've been thinking of it in two smaller terms, Ashwin. Because I don't do Inspire, I'm typically referring that to either my two partners or there's a couple other folks in my proximity that do a great job with that in other practices. So I think actually I do the awake endoscopy, really looking critically at the nasal airway. I do send a decent amount of patients for CPAP still, but a decent amount of patients for oral appliance therapy as well. I rarely do any pharyngeal surgery outside of tonsillectomy. And rarely do I think of that first line. If I'm doing a procedure first line, it's going to be something nasal, and usually a combination. Septoplasty, treating the valve, treating the turbinates, treating the swell body. And I find really anecdotally good results, and there's data to back it up, that even treating chronic rhinitis patients, whether it's allergic rhinitis or non-allergic or vasomotor rhinitis, they do better too because they're not drowning on that mucus all night. The sleep quality is better. The tolerance of CPAP, especially with the nasal delivery, is much better.
Yeah, that one's interesting to me. The like doing a posterior nasal nerve ablation would help with sleep quality. Like I suppose as we kind of talk it through and just talk about it.
The data is good. Yeah, all three technologies that are out there. Of course, there's one cryotherapy, the Clarifix, that's now Stryker, was a company called Aerin. And then there's two radiofrequency options, the Aerin Medical one called the RhinAer, and the Neurint, the medical device, the Neuromark, which I personally have not used, but many of our colleagues think highly of that product too. So even just treating the posterior nasal nerve, the data is good that it improves sleep quality. What I do in my practice, and Ashwin, I'd love your thoughts, and Ashley, you too. I choose the RhinAer more often than not because I can also use that to treat the turbinates and treat the septal swell body. And so I love the option of treating the congestion, the actual mechanical obstruction, in addition to the autonomic innervation of the turbinate, making the snot, making the mucus. Others may feel differently, that they get good enough results just with treating the PNN.
RhinAer, as far as PNN treatments and chronic rhinitis treatments, allergic or non-allergic rhinitis, the Aerin Medical, the RhinAer, is my favorite. I was a very, 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 very skeptical at the beginning because I hadn't done it in residency. I hadn't done it in fellowship. Residency and fellowship, I did Clarifix, and we did, as a counterpart to the VivAer, we did full rhinoplasties or functional rhinoplasties a lot. So I had no experience with Neuromark or RhinAer or VivAer coming into practice. And it's funny, my local rep reminds me the first time I ever did one, I was pretty nervous. And I said, look, I just don't want to kill this person. And he laughed at me. And now I love offering it because it's so safe and it's very effective. The effectiveness has blown me away because of how easy it is to do.
It's quick.
And how happy the patients are. It has helped me not think twice about offering it. The reimbursement was great. Now it's good, which only helps. But the ease of recovery for the patient, they get up out of the chair and they walk out and they drive home. And the effectiveness, which has been very, very, very favorable, and the safety, knock on wood, I haven't had a single serious complication, has been fantastic. So in terms of PNN treatment, I totally agree. I think it has something to do with postnasal drip and like retained secretions in the tongue base or the pharynx of something that triggers some kind of cough or gag reflex and wakes you up. That's my personal theory on why the PNN treatment helps for that. But you're also doing the turbinates and the swell body also. So maybe it's something about nasal flow and airway obstruction coupled with that. I haven't done PNN treatments alone, and I haven't done anything other than the RhinAer in practice, other than like one Neuromark.
In fairness to the other two, I mean, I prefer the RhinAer because of the being able to treat 3 spots, but the data is good on patients' perception of airflow. I know with the Clarifix, and I would presume with the Neuromark too.
So that's the outcome that they're looking at is like nasal, like airway scores, or like, is there a...
Yeah, exactly.
Did they
Whether
look
it's
at
the
sleep?
SNOT-22 or other TNSS, whatever, patients feel like they're moving more air with all of it. And that's got to be helpful for OSA, right? It's got to be helpful.
I'm going to bust out some physics. The radius to the 4th power, right? So the radius to the 4th power, what that means to me is that a tiny increase in the nasal airway will impact flow exponentially. And my correlate is like subglottic stenosis, and that classification of subglottic stenosis where it's like the child has no symptoms, the child has no symptoms, and then all of a sudden the child has stridor and problems. I think the nose is the same way. You have a threshold at which you perceive nasal obstruction, even though there is some flow. If you get above that threshold, then whether that be with just a tiny little radio frequency or that be with bony surgery or mucosal with real operative surgery like we do, you get above that threshold and the flow gets to a point where the patient doesn't perceive nasal obstruction anymore. So that's my physics theory.
That's a really, I'm glad you brought that up. That's not too scary physics. I can understand that at least. And I say that 10 times a day, is that if I give you 2 millimeters, you're going to feel like I opened your airway 16 millimeters. And patients really do. And that's what's been fun for me to see the evolution. You guys trained when there already were office procedures, but I didn't. And so seeing that really come to fruition in 2011, the difference when patients could tell us in the chair, well, doc, whatever you just did, even if I ballooned a maxillary sinus or whatever, seeing that Bernoulli principle in real life, the second I took the balloon out, say, whatever you just did, I can breathe better. It's like you're holding a fan up to my nose. And to the point I used to think it was a placebo or it was the Aerin, but we now know, no, that's actually true. We're taking a 2 millimeter os and making it 6 millimeters. The patient feels that right away. And I think it's the same with these treatments of the turbinates and the swell bodies.
So as we kind of round out our discussion, is there anything that we have missed that you want to make sure that we leave our listeners with?
I think it's always the admonition to, as ENTs, this is our disease to really quarterback. You know, we have so many good colleagues in other adjacent specialties that can help us, but really it's our anatomy. And I encourage us to be more proactive, both with our physical exams and just our communications of the importance, especially of nasal obstruction in treating obstructive sleep apnea, especially, Ashwin, as you said at the outset, CPAP failures, but oral appliance failures too. I mean, I have a lot of really sharp dental colleagues that have recognized that on their own. When they're not having the results they expect with an oral appliance, they send them back and say, take a look at their nose and make sure they have good airflow. And sure enough, 70% of the time, that can be improved. And then magically, the oral appliance works better. So I think the whole point of this tonight is to really remember the nose in treating these patients.
Yeah, if I could leave with one thing, I think, Keith, you said it perfectly. One thing I didn't touch on, and this gets into a little bit more sleep, is the AHI as a measure of disease severity. So the AHI it's a flawed metric, and anybody will tell you that. It combines apneas and hypopneas and divides them by total sleep time. So a hypopnea is scored the same as an apnea. So somebody can have a really high AHI and not really have that severe of a disease burden, where somebody can be having really bad desaturations, have a whole lot of hypoxia, and their AHI is actually lower. Treating the nose will improve a patient's quality of life and improve a patient's ability to adhere to any other OSA therapy. So don't bank on just the AHI going down, because sometimes it's not that. And I caught a lot of flack
great point
from other sleep physicians for Inspire, for other things I've done, where the AHI didn't get to 0 and it didn't get to as good as I'd wanted it to. But the patient in the chair says, I sleep so much better. I feel so much better. My blood pressure is better. Everything's better. There's more to it than just the AHI. We need to look a little bit closer at the hypoxic burden.
Yeah,
what is driving the AHI? Is it hypopneas or apneas? And what is the patient saying? So nasal treatment is extremely effective for all the things around sleep apnea. And it's effective somewhat for AHI too, but it's so much more effective for making anything else work better. So I believe in it.
Well said.
So if the AHI, if you haven't seen a lot of improvement, but the patient is telling you, I'm sleeping better, I feel better, and there aren't other alarm bells, you could potentially stop.
Look at the oxygen, right? The hypoxic burden, what we're talking about is the time that a patient is under 90%, essentially, however you define it. As you said, Ashwin, someone may only have 5 apneas an hour, but if they're each 2 minutes long, they're going to spend most of that hour under 90% and down in the 60s and 50s, right? But that's only an AHI of 5. And that's an extreme example, but that's possible. That's why the AHI is quite flawed in looking at efficacy of treatment. But I feel like if you look at the patient's oxygen throughout their sleep time, then you really know a lot about the quality of sleep. You got to look at their EEG, you got to look at a lot of other parameters. But I think if you had to pick one thing, if you know their oxygen is above 90% or higher, then their airway's open and they're respirating. I mean, that's maybe too commonsensical, but I think that's what it's all about, right? Breathing and oxygenating.
Yeah, I meant it to say, like, don't be dissuaded of any sleep intervention based upon a modest reduction in AHI, because there could be more to it. You could have converted really bad apneas, like you're referencing, into a couple hypopneas for every apnea, but now they're not desaturating. But your sleep colleague might just look at that AHI and say, it didn't budge, what you did is bogus. But it's not, because that patient's going to say, I feel better, I sleep better, things are better. Thank you. So that's what I'm saying, to look at the treatment as a process that involves the patient and how they feel, rather than just an AHI number. So your question, Ashley, if you did the intervention and the AHI is still there, I look at it like I'm not a jailer. I don't tell people what to do. I just kind of educate them about their health condition. So any AHI, the long-term data it also has its caveats, but what we seem to know is moderate to severe OSA and AHI over 15 will lead to long-term health consequences, where below, maybe not so much. So I tell them that, and if their AHI is over 15, we think about going to the next step, whether that be retrial of CPAP, some type of surgery, or making a device or referral, something like that.
While also recognizing that one AHI is not the same as somebody else's AHI, even though that's been the measure that has been chosen for OSA severity. There's more to it. Look at more than just that one number. Yeah,
unfortunately, that's the rules we got to play by, because that's what gets approved and denied based on that one number.
By our friends, again, by our friends.
That's right.
Awesome. Well, thank you both so much for taking the time to chat with me about this. This has been really great and really informative. If listeners want to find you or reach out to you, are there any social media handles that you would like to plug?
I'm real active on LinkedIn professionally. So, just my name, Keith Matheny. Love to interact with folks on that platform.
I'm on LinkedIn too, I think. I'm not on Facebook or Twitter or anything like that, but I have a website. It's drashwinent.com. So you can send me a message on there.
Sounds good. Thank you.
Thank you so much, Ashley.
Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.